Good morning, everybody. I welcome you all on behalf of the Candy Society of Medicine for the Wednesday CME lecture. First of all, about the upcoming events, we are planning to have a certificate course in endocrinology on the 19th of January. Also, I would like to remind you about the KSM annual academic sessions on the 7th, 8th, 9th, and 10th of April. Also, there is a PubMed webinar on the 24th, Sunday at 6 p.m. I also like to remind about for you all can purchase the KSM tie and the t-shirt from our office. There's a new tie and a t-shirt. Coming to the today's lecture, speaker is not outsider to our society. He's a member of the KSM ENT Surgeon, Dr. A.B.Kiridana, MBBS, MS, DOHNS. Dr. Kiridana graduated from Peradeniya Medical Faculty, graduate in UK, and as ENT surgeon, he has worked at Matale, Kegal, and currently he is the ENT surgeon at Kurunegala. This is an interactive session, and the topic is ENT for day-to-day practice. I will call upon Dr. Kiridana to deliver the lecture.
Good morning, everybody, and thank you, Kavinda, for the introduction. I'm going to discuss very common topics what we see in day-to-day practice, and I have identified some areas where it is mismanaged and it can easily be managed. The possibility of easily managing it in the proper way. So we'll discuss some of these areas. First, let's see this scenario. A 50-year-old female had a sudden attack of rotatory vertigo, which has persisted over the last 3 hours with nausea and vomiting. There are no other ENT ear symptoms, and she keeps the head standstill. Since the vertigo and nausea get aggravated with head movements. So with this history, what comes into your mind? There are key things. Of course, she has vertigo, and it persists over the last 3 hours with nausea and vomiting, and the vertigo aggravates with head movements. Any idea? These are the common ones. Let's see each one separately. Can it be Meniere's? We know Meniere's, they have other ear symptoms like reduced hearing, tinnitus, right? So those are not there. So we can sort of forget about Meniere's. And what is medical disease? What I put that here, we see a lot of patients, especially in the medical clinics, they have dizziness and they may be taking antihypertensives. They may be taking a lot of other drugs, sedatives. So they are dizzy all the time, right? Sometimes they have neuropathies, diabetes, right? Due to aging, neurodegenerative problems, they are dizzy. So I basically categorize all of them under medical dizziness. So is it BPPV? The key here is, it says vertigo aggravates with head movements. So this is the tricky area. Everybody now says vertigo. If somebody is having vertigo and it aggravates with head movements, they come to the conclusion that it's BPV. But here it's not. The reasons are like this. It says vertigo persists over the last 3 hours. So BPPV is very unlikely. The key I am always highlighting is vertigo with aggravates with head movements. It's a feature in peripheral type of vertigo. It's seen in BPPV, but it's seen in all the other peripheral vestibular problems. Like in Meniere's, you see this. Vestibular neuritis, labyrinthitis, all the other ear problems, you see this aggravation of vertigo with head movements. But BPPV is lasts only for few seconds, maximum 1 or 2 minutes, not more than that. So if it lasts for 3 hours, BPPV is very unlikely. So the other one is vestibular neuritis or labyrinthitis. So here most probably it's vestibular neuritis because he has no ear symptoms. In labyrinthitis, they have reduced hearing, but these two goes together. So according to the newer classification, it says acute unilateral vestibulopathy without dividing that into either vestibular neuritis or labyrinthitis. So in this case, out of these 4 is the first one which fits into this scenario. If you have any questions, you can just come up. I'm not going to disturb you, right? And let's see the second scenario. A 60-year-old gentleman admitted to the hospital 2 days back with sudden onset of vertigo with right-sided reduced hearing. Now, 2 days history with right-sided hearing loss. On discharge, he has right-sided reduced hearing, persistent mild vertigo with aggravates with head movements. Again, it's aggravated head movements, right-sided tinnitus, and he has oral fullness as well. So here, so now the patient is going to get discharged. So what is the diagnosis that you write in the diagnosis card? Is it Meniere's? Because we know Meniere's, it has basically 3 or 4 symptoms: reduced hearing, tinnitus, vertigo, with or without oral fullness. All 4, they are here, right? So can it be Meniere's? Number 2, medical dizziness. Now here they have vertigo and ear symptoms. So medical dizziness is unlikely. BPPV. Again, it says for 2 days and they have ear symptoms also. BPPV, they don't have other ear symptoms. That's again out. So it's labyrinthitis or vestibular neuritis. Meniere's disease, if you have these 4 symptoms, it's called Meniere's syndrome. But Meniere's disease is a separate entity where you have endolymphatic hydrops. There's increased pressure in the endolymph. And that gives rise to these symptoms, and also it is idiopathy, right? And they have fluctuating hearing loss, and the vertigo doesn't last for days. I'll come into that in a separate slide. So here the most likely diagnosis is labyrinthitis. Vestibular neuritis is also unlikely because they have reduced hearing also, but these two goes together as I mentioned earlier. So I have seen a lot of diagnosis part from in patients who discharge from medical wards saying BPPV merely because they have vertigo with head movements. So one thing to remember is vertigo with head movements is not equal to BPPV. There are a lot of other things that you have to remember. This is another one. 35-year-old lady present with rotatory vertigo which occurs with head movements, no other ear symptoms. Right? So rotatory vertigo, no other ear symptoms. So what is the next single most important question that you are going to ask? Anybody? Yeah. Anything else? One more question. What is the very important question? It's the duration. Duration of vertigo. Right? So let's say it's few seconds or 1 minute. What are you going to do? So what is the most important bedside test that you are going to do? It's the Dix hole pipe test, right? And here also why I put this slide is, I mean, there are a lot of patients come with this and they do a lot of investigations, including NCCT brain and a lot of other investigations, and they admit the patient, stay there, and in private sector, the patient cost about 40 to 50,000 rupees minimum. Right? So what they need is one more question in the history and bedside examination, Dix-Hole pipe test, and the most, if the Dix-Hole pipe test is positive, and the most possible diagnosis is BPPV, and BPPV can happen in all three canals. The posterior canal is the commonest, and for that we do a maneuver called place maneuver. If you do that, you can cure the patient. So the importance is if you diagnose correctly, the patient will not have to stay long and will not have to spend 40 to 50,000 rupees, and the diagnosis will take only 2 minutes and the treatment will take another 2 minutes, and you can cure the patient without a pill, right? So what is the management? It's the now this is the Dix-Hole pipe maneuver, and it's much worth to do this test than doing CTs and other lot of investigations. Because what you have to do is just get up from the seat and do this. It takes only 2 minutes. And I'm not going to detail in this test because it was done recently and also it's available in the internet. You can easily see if there are videos, right? It's easy to learn, and you can do this test. The management is replacement. This again takes about 2-3 minutes only. You can treat the patient and it's very rewarding. You do that, you cure the disabling disease without a pill in 2-3 minutes. So this is again available in the internet. You can see it's a plate maneuver which is done for posterior canal BPPV. So this is the treatment. So few words about vertigo. We can divide it into mainly two categories: vestibular and non-vestibular. As I told earlier, medical. The medical includes the cardiac, diabetic related, drug related, right, psychiatric, anemic, metabolic diseases, ocular diseases, all those things comes into one group, and the other one is vestibular. Then again, the vestibular one we can divide it into two: peripheral vestibular, that is, if the disease involves anything distal to the vestibular nucleus, they are called peripheral. The list of things are there, right? They are peripheral, and the rest is which involves above. The commonest ones are the CVS, migraine, neoplastic diseases. So there are ways other than the CT scan and imaging, clinical history and investigation to differentiate these things. So this is not a lecture on vertigo, so I'm not going to discuss these things. But you can differentiate these things in history and examination, because vertigo diagnosis depends about 70 to 80% on history, and the next on examination, and very little rely on investigations. But we are practicing the other way. When the patient gets admitted, 1 or 2 words and maybe 1 or 2 examinations and go for investigations. But mostly can be diagnosed with this. Now, this is a very important slide. You can even take a picture. Now, this says how to, especially the vestibular vertigo. how to narrow down your diagnosis. If the attack lasts for few seconds, and if it is peripheral type, the most possible diagnosis is BPPV. There are other things also. At least remember BPPV. If you suspect BPPV, the vertigo should not last more than a minute or two. And in central type, it's the commonest one is VBI or a TIA. If the vertigo lasts for minutes or hours, the peripheral type is the Meniere's disease. Typically, it lasts for 20 minutes to 20 hours. In central type, it's the migraine which lasts for 5 minutes to 72 hours. The attack can last for 5 minutes to 72 hours. The window is a bit broader there. And if the vertigo lasts for days and weeks, and I remember I discussed the first two slides, it says the vertigo lasts for 3 days, 2 days, then the peripheral type is the commonest one is, as I mentioned, acute unilateral vestibulopathy. In central type, it's the commonest thing is CBA, involving brainstem or cerebellum. There are ways to differentiate these two. And if it lasts for long, days, weeks, months, and years sometimes, the peripheral time, we have to think of acoustic neuroma, bilateral vestibulopathy. But if you go and see medical clinics, all of them are having. They are either neurodegenerative disorders or medical, so-called medical diseases. Mostly maybe because of our drugs. So treatment for those is not stimulated, not vestibular sedation. So this is a very important slide. At least if you have this one, we can narrow down our diagnosis. Now the last one, a 70-year-old man with well-controlled hypertension, diabetics, complains of dizziness, which increases with getting up. He also complains of hearing loss and continuous type of tinnitus. What is it? Now it has hearing loss and continuous type of tinnitus. If you take 70-year-old, 80-year-old people, do you think their hearing is normal? Don't know. Right? You know about this presbyacusis, which is Hatalis adria. So after 40, the vision gradually goes down. The similar thing happens to hearing as well. Right? So likewise, if they are 70, the hearing is anyway low. And when the hearing is low, they can have tinnitus as well. And the other thing is they are not having this typical dizziness, they're having the typical vertigo, they're having dizziness. So most probably this man is having so-called medical dizziness. So for them, sometimes they diagnose many years also because they have hearing loss, tinnitus, dizziness. Right? Migraine unlikely. Yeah, neurodegenerative disorders possible. Vestibular neuritis is unlikely though they have hearing loss and tinnitus or medical dizziness is the diagnosis. So for them, the treatment is not vestibular sedatives, not stimulating loss energy. If you give them, initially they might get better, but you disable them for the rest of their life. Right? Now, let's move from vertigo, which usually if I continue to do that, you might get dizzy. So you might get into something easier and something that you see in everyday life. So on routine ear examination in your practice, you see wax here in the ear canal, but you can partially, drum can be seen partially and it looks normal. It's something like this. And this is like you see feces in the rectum, right? So this sort of wax you should not worry about unless they have symptoms. And this will not cause reduced hearing. What you should do is, if it is a patient, just reassurance. Or if necessary, you can put something like olive oil that will come out. Even don't try to clean it. Not necessary. If you try to clean your ears unnecessary, that will create problems. I'll discuss that later. So you don't need anything. Young tourist comes to see you with sudden onset hearing loss following a sea bath. Now they say I spent yesterday at Hikkaduwa, and I came here. I came to Kandy yesterday evening. I can't hear. My one ear is blocked. What's the diagnosis? What do you think? Any idea? Simple thing is the simple wax. What happens? The one he had wax in the ear, which was dry, and after the bath, the water goes in, it swells up. So this is very common. After a bath, if you get a hearing loss, it's due to wax, and this wax can be either sucked out or syringed, and the patient get better. But the wax problems, they are sometimes not that easy. A young girl present to you with severe unilateral otalgia and ear fullness. The ear is tender. On otoscopic examination, the ear is full of wax. Now these ones is not that easy to manage. You get impacted wax. So you have few categories. You have loose wax, right? You have impacted wax. The other one is called wax keratosis. Impacted wax is you have hard wax there. You have to loosen the wax. Sometimes that is painful. The wax keratosis is you have wax. You have wax in the ear, so it's blocked. So still the ear produces more and more wax. So this wax, they have lysosomes, and also it exerts pressure. So the ear deep canal enlarges. So you have a small outer canal, but large deep canal, and it also exerts pressure on the eardrum. So we have a very thin attenuated drum, and sometimes it pushes the drum into the middle ear and destroys the ear structures, also middle ear structures. Suddenly, if it gets infected, the water goes in, this swells up and exerts pressure on the bone, causing severe pain. Severe pain. I have seen adult males, they are crying. These sometimes needs either you can do EUM or you have to remove it under general anesthesia. So this is very, very painful. So how to clean the ears or remove the wax? The best way is under microscope because you can see it properly. If not, the second best is ear suction, less complications, and then ear syringing and ear hook. This has its own complications, even ear syringing. And if you are doing ear syringing, you should know when to do it, and there are contraindications. Right, when there are ear infections, perforated drum, you should not do it. And if the ear is full, like in DOHNS or keratosis, you can't do it. You can see from the upper diagram, you should direct the water which is warm to one, usually to the roof, and when it comes back, the wax comes out. But when the ear is full, completely blocked, then you can't do it. Right? And you have to be very careful and traumatize the ears. So you should know when to do and when not to do ear syringing. Little bit about wax. And wax normally forms in the ear and it comes out. They are in different colors and different shapes and different textures. All these are normal. They have yellow wax, brown, and black. And sometimes you see they are coming like scales. And sometimes the balls rolling out, and sometimes liquids coming out. All those are normal. And sometimes the patient comes and say, I have bleeding in the ear, blood in the ear. To see that it's brownish wax. But you should not try to clean it. While it is inside, when it comes out, you can just clean it, right? And that's a very sort of important thing happening in the ear. This is only seen in the ear, migration of the skin. Usually the ear skin is formed in this area. It's called umbo, and it gradually migrates out. There are researchers done, and they put ink drop here and examine repeatedly. They have noticed the ink is moving. So whatever the wax and whatever the foreign body, may be a piece of wax or a foreign body, that also comes out. This is helped by the movement of the jaw. When you move the jaw, the canal also, the wall moves. So that migration is helped by the jaw movements. But what happened is cotton buds, you absorb the moisture and push the hard wax inside. And also you irritate the ear so that it will produce more and more wax. So that is one of the causes for this impacted wax. And also by doing that, if you traumatize the ear, and that will end up with otitis externa. It's a very common cause, the commonest cause for otitis externa. Now, another scenario: a child present with otalgia following upper respiratory tract infection, and the ear is non-tender. What is the most possible diagnosis? Is acute otitis media, right? They are very common. A young adult present with otalgia severe, the ear is tender, and there should be something in the external ear. So it can be either wax or otitis externa, something in the external ear, or it may be a tick or something in the ear. But if the ear is not tender, external ear problems are unlikely, right? But now we can discuss like this. Can say otitis, acute otitis media, the management is like that. What you see in the eardrum is like that, and otitis externa is like that. But the patients will not come like that. Patients will come in this way. A child 3 years old, present with otalgia. These are two cases. Present with otalgia following upper respiratory tract infection. So it mimics acute otitis media, but ear is tender. Right? The pain is intermittent, and the child is well in between attacks. So what you should do next? Examine the ear. So Jayanta and Vasana is here. So examining the child with tender ear is not that easy. So these are practical problems. So you will not be able to examine it. Now there's a disease, attic disease, this part, this part, this part. The child is crying, and if you touch the ear, they scream, right? So that this is the clinical, this is a proper picture, right? So anyhow you examine. So it can be acute otitis media, it can be wax, or it can be a tick. You examine, you see this. So it is acute otitis media. Never know. You don't know, the history suggests, but you can't see it. Is it wax? Yes, possible. Is it a tick? Possible. Why I put this slide is I've seen a lot of cases where they were treated for otitis media, and we remove wax and we see ticks inside. So the best treatment for this patient is you treat acute otitis media, you treat the wax and the tick at the same time. So best thing is I put them on olive oil, dissolve the wax, and also it helps to in killing the tick. So the next one is if they are having severe pain, EUA. Examine it under anesthesia, remove the wax. If there's a tick, remove it, and then you have a diagnosis. Otherwise, it's a very difficult situation. We know how to manage acute otitis. We don't know how to manage wax. We know what to do for ticks. But in these clinical situations, we are in trouble. So have you seen this? Called baludam. They are ticks, right? So it's a big problem. There are different ways of managing from just removal under anesthesia or syringing, and various people put various things, allocaine and glycerin, olive oil, various, and there's no proper technique or proper way of putting it. And we can kill these insects by putting oil, right? But if the patient is having pain, and then we'll have to remove it somehow. I know this is a very common thing in children and in female. I don't know. Somebody can do a study and see whether these ticks are males because they prefer women and children. It's very rare to get ticks in males. I don't know the reason. Common as children and then women. This is again a very common thing that we come across. A young adult presents with otalgia with no other ear symptoms. What do you do? These patients, when they come to us, they had antibiotic drops, augmentin, cetirizine, brufen, PCM, maybe Zinet, right? But to see the eardrum is normal, and there's no evidence of even no evidence of recent ear infection. So what it is? So if you can't see anything, then you have to suspect this may not be pain, may not be in the ear. So we have to suspect referred pain. So don't just treat them, because this is very common in young adults. It's the impacted ear or erupting teeth, even in children. Or it may be carried teeth, giving rise to these otalgia. No point in wasting money. Zinet and things are very expensive, but you treat them without looking into the ear. So please exclude all the possible cases, causes before treating. This section I'm not going to detail. There are causes, and this is a common finding that we see. Otitis externa, and the most important thing is oral toileting. Suction is better because when there's an infection, you should avoid syringing as much as possible. And in this one, suction and also drops will not help because there's no ear canal. It's all closed because of the edema. So somehow you would have to do suctioning and put a pressure dressing, either Popic or a wick. You exert pressure on the walls so that you get the normal otary canal. Then after that you can put drops. This is again very common. Photomycosis of fungal. This is Aspergillus nigra, the first one. There the most important thing is oral toileting, and sometimes we have to do it repeatedly with local antifungal agents. Right? Just antifungal will not help because they might not reach the deep part. So oral toileting plus antifungal. The local treatment is enough antifungal. At the same time, you have to see why they are getting it. The commonest is cotton bud usage, and sometimes immunosuppressive conditions, diabetes, or antibiotics. Two cases, a patient present with long-lasting on and off smelly ear discharge with reduced hearing on one side. The other one, patient present with long-standing copious discharge. Now, which one is more dangerous? The second one troubles the patient and troubles us because a pouring discharge. The other one is having mild on and off discharge, but as smelly. But the first one, you examine, you see this, and there's a cholestatum. This is the dangerous type. This one, though it's pouring, it's not that dangerous. Now, another one is when there's a eardrum, whether to put aminoglycosides or gentamicin drops. This is a very common question and there's no proper answer. There are arguments for and against because we put gentamicin intratympanic to destroy the vestibular function. Here we put gentamicin into the middle ear to treat the middle ear problem. So contradicting principles. So what I think is there are no reported cases by getting vestibular toxicity with local drops. Maybe because the drops the concentration of gentamicin is low. We put IV gentamicin into the middle ear to treat Meniere's disease to destroy the vestibular function. But if you want to sort of safeguard yourself, you can always put now most of the time is chronic otitis media is pseudomonas. You can put ciprofloxacin eardrops. That in the British pharmacopoeia, cipro eardrops is not in the British pharmacopoeia. It's only gentamicin. Right? Yeah. In England, if we prescribe ciprofloxacin, the pharmacist call back and ask, doctor, you have prescribed eye drops for the ear. Is it all right? Then we have to say, it's all right. You go on. Like that. So here, no, even if you can put anything, nobody will question you. But you can put ciprofloxacin or gentamicin. It's okay. The other one is for chronic CSOM. Pseudomonas is the cause. You can always make the ear can make it acidic by putting acetic acid or boric acid. So the growth of pseudomonas can be minimized. What is this? This is a traumatic perforation. Now here I have seen a lot of patients, so a lot of people managing this with antibiotics and drops, which is not necessary. If the ear is healthy, no infection, the patient is not having upper respiratory tract infections, you don't need anything. These perforations will heal over 90-95% heal on its own. If you give antibiotics, it's useless. If you put drops, and the drops will make this sort of moist and can introduce infections. So the best thing is just leave it alone. Ask the patient, reassure them, ask the patient not to wet it, and we can draw it and draw the size, and maybe we see the patient maybe in a month's time. Or ideally, we can wait for 6 months, 1 year till it heals. Problem comes when it gets infected. Another one, the mother says that the child is having recurrent upper respiratory tract infections and snoring and is backwards in studies. Now this one, when we examine the ear, we see something like that. What is it? Fluid in the ear. There are various names, otitis media with effusion, low ear, various names. So if you check the hearing, there's a conductive deafness. These patients, what is the management? It's not traumas. Initially, we can treat them medically. If it is not responding and if it is affecting their day-to-day activities, and especially if they're having snoring and also obstructive apnea, and then we can go for surgery. Grommet insertion with or without adenoidectomy or adenotoxicectomy. A soft-spoken lady in a middle age complained of bilateral reduced hearing, no other ear symptoms, no even fast history of ear disease. Here also we have to examine the ear. Ears are perfectly normal. If you do the hearing assessment, ear conductive hearing loss. What is it? There's a conductive hearing loss and there's a dip at 2000. So it's most likely autosclerosis. Autosclerosis is, now you know there are 3 ossicles and the stapes foot plate is fixed. You know, the vibration has to transmit from the middle ear into the inner ear. So that transmission is through this bone, stapes, and the foot plate should move here and there, and it should transmit the pressure, the sound wave to the middle ear. But in this condition, this foot plate is fixed, so it's not moving. These patients need surgery. So what we do is we remove the stapes suprastructure and make a hole there and put a piston like this. So in actual picture, you see this, and here you see the malleus and the drum is folded forward, and here what you see is the loan process of incus. You can see the piston, and there's a hole in the made in the oval window, so the piston is moving. Right here you can see the facial nerve is here, and this is the stapedius tendon which is cut. Usually it's attached here. Right. So the surgery is like switching on the radio. If you do it under local, do the surgery, put the piston correctly, put the flap back, the patient starts talking, starts hearing. And if you do it under local, it's very rewarding. If you do it under GA, then you have to pack it afterwards. It takes some time. But when you do under local, you can the success of the surgery can be checked then and there. Earlier you talk to the patient, they will not answer. As soon as you put the flap back, you answer question, start answering. Yeah, this is again a very good scenario for people who are doing private practice. A young man, 30 years old, presents with 2 days history of sudden onset hearing loss, sudden onset unilateral hearing loss, comes to your practice. What are you going to do? Of course, you have to examine the ear. And if you don't have a horoscope, you can use a ear, but if you are treating the ears, you have to have a horoscope. If you don't have horoscope, it's like a gynecologist not having a finger, right? Or else Dr. Madhakendra going without a stethoscope, right? So if you want to treat properly, you have to have a horoscope. Otherwise, don't treat because you don't know what is happening. If possible, check the hearing. Right? You have to always check the ears. If you can do this, go ahead. So if you examine, it can be perforation, it can be acute otitis media, it can be wax, or it can be fluid in the ear, or it can be a normal ear. Right? So little bit about hearing loss. It can be a conductive hearing loss or sensorineural hearing loss. And if there's a mixed type, it's called mixed. So there are 3 types: conductive, mixed, and sensorineural hearing loss. Conductive hearing loss is caused by problems in the either external or middle ear. So some of them can be seen, like wax, otitis externa, glue ear, acute otitis media can be seen, but some of the things you can't see with the horoscope, like otosclerosis, ossicular problems, you can't see. The sensory neural ones you can divide into 2: sensory, that is cochlear problem; neural is the neural problem. And it can be age related. There are various causes, but if you can identify a cause, then you can treat it. If not, there are viral, inflammatory, and idiopathic causes. What is important is, if you can identify a cause, then you can treat. If you can't identify, if it is sudden onset and it's acute, that means 1 or 2 days, it can be cured. Either viral, inflammatory, or some of the idiopathics can be treated with intratympanic dexamethasone injection or with antiviral treatments. So these patients, what I want to say is, if you can't identify a cause, Don't just treat them. Send them immediately. Because if go to the studies, if you give them intratympanic dexamethasone within 72 hours, there are some good response. But if it is late, maybe 2-3 weeks, the response is poor. So if you want to try, we have to give them early. So if you can identify the cause, treat it. If you can't, please send them immediately. So we can treat them. So this is one of the things again that I wanted to highlight. The hearing aids, I am not going to discuss this in detail. There are analog pocket type of body worn hearing aids, and it's a spectrum. And spectrum, the other end, it has mid-ear implants. You fix the hearing aid into into ossicles. And there are, it's called Baha bone anchored hearing aids. We use these things for patients with external ear problems. Like sometimes we have children with no ears, microtia, anotia. For those patients, and sometimes with ear infections, we can treat with bone anchored hearing. The digital hearing aids, also there's a spectrum behind the ear type hearing aids, and in one end and the other end you can put canal type inside the ear so nobody can notice it. And also you have cochlear implants for sensory hearing loss. So if somebody asks, what is the purpose of the ear? Can you answer? Why do you have an ear? It's a simple question, right? You can't just show these the purposes of the ear, right? So there are a lot of purposes. You have to protect it. Right. When the time is, just let me know. Yeah, about tonsils, a mother complains that my child doesn't swallow and keeps the rice and curry in the mouth and play. And to see, they have large tonsils. Now we have to be a little careful about the size of the tonsil, because we are not going to treat anybody for its size. Sometimes you can see this one, let's say the first one, and this tonsil, though it is small, it can cause all the problems. But the large one, you open the mouth and you can't see a single space. You can see a small space, and I don't know, the child is eating, but you can't see anything. But the child is eating, there's no snoring. Right? For second one, you don't have to treat. But the first one, though the tonsil is small, you have to treat. And this, if you go into this scenario, and sometimes when the child doesn't like food, especially rice and curry, they attribute this into something. Right? So we have to be careful. The child can't eat rice and curry, but they can eat maybe pizza. So all sort of kadachol. So we have to be careful with the children. They are very cunning sometimes. They are well ahead of us. So we should not go and treat the tonsils merely because the child refused to eat rice and curry. Is again a very common, especially these days, because the people, they are worried about their throat because of this corona thing. And for years they never look at their throat. They only see their teeth and the tongue. And suddenly, if they get something in the throat, they go to the mirror and open the mouth to see that they have something like this. And not corona, they see stars, they think this is a cancer. So what is this? And in younger young adults, they come with, after doing all sort of experiments. They remove these things, smell these things, brush these things, do everything. And recently I have found out when they remove this, get a pit. And recently one patient, not only after checking all those things, he has put something into this hole. And he has found something funny inside, something like a stone. That patient, he will be coming on next Monday for us to do oil and see inside. So what is this? They are worried. See, why I put two small kids? When they have kids, the mothers are more worried because they think this is a cancer. So this is called tonsillar keratosis. What happens is similarly now. This is completely normal thing. So how I educate the patients is I ask when they from the skin also you get lot of debris, so-called kunu. So as yes, similarly you get this sort of desquamated epithelium in the mouth, in the tongue and the cheeks. When you eat, when you brush, it goes. You swallow it. But these tonsils, they are not smooth. They have tonsillar clefts or pits. So these sloughs get accumulated there. Sloughs or keratin, they get accumulated there. And when it is full, you swallow it and you end up with a pit. And after some time, the pit fills up again. So this is completely a common sort of normal thing. And what you need is just reassurance. And for the same thing, I have a big photo in my consultation room, so I can show them. Otherwise, it's very difficult to reassure. And sometimes put the name and for young people and ask them to go and read and type this into Google and put the images, and you will see all sort of things, all these sort of things. Otherwise, it's very difficult. They go from one doctor to another if you don't reassure properly. And sometimes these can cause stones, right? So that the person I told you has put something and found a stone called tonsillar leads. And the largest one I removed about 2 centimeter size, right? So they can have a necklace or pendant that if they want, they can smell it. It has a very nice smell. So these are called tonsillar stones, tonsillar leads. And the other one is this. This is a tonsillar cyst or retention cyst. This is again common and again harmless. If there are symptoms, you don't have to do anything. But if they are really worried, you can take a needle and rupture it, puncture it. And the other two acute tonsillitis. Yeah, another one is peritonsil abscess or peritonsillitis. They come with unilateral throat pain. And typically, when they come to you and speak, then you can identify the speech is called hot potato voice. It's like keeping a hot potato in your mouth and speaking. Typical that sound. Then when you have that, you can identify. And sometimes they have severe trismus. You can't even see the throat. You can do incision drainage or aspiration, and we have to be very careful. And sometimes parapharyngeal tumors can come like that. So, think to differentiate. They have inflammatory signs, and also in peritonsil abscesses, the uvula is pushed to the opposite side. But if it is in the if it is a parapharyngeal space tumor or something, usually the uvula is not pushed. Sometimes the aneurysm also can present like this. So before putting the knife, you have to be a bit careful. You have to diagnose it properly. This is how you do IND. Another one, and a patient present with a neck lump and suggest you meds. So what are you going to do? Yes, ultrasound and FNAC. Most of these metastases, they are squamous cell carcinomas, and be diagnosed with FNAC. Even all of the thyroids, including follicular, can be diagnosed with FNAC. So we should avoid open biopsies. Because if you do open biopsies, one thing is you spread the tumor into the skin, subdermal lymphatics. And if you were to do biopsy, put the incision in such a way that you can catch that in a later, if you need a block dissection, you can catch the incision and remove it. Otherwise, block dissection is difficult, and you can't decide the incision if you put haphazard incisions in the neck. So where these patients should be managed? I think if you get a patient with neck knock and if you suspect malignancy mets, and better manage in the ENT unit, merely because not the others are not capable. Let's say if you do now right to ultrasound, it takes some time, and if you do FNAC, you have to give a date, and it takes few days, and you have to wait till the results come. It comes as malignant smear or squamous cell carcinoma, right? Then sometimes you have to repeat it. Then you have to check inside. Then you have to refer, and the referral will take some more time. Then we'll have to do a FOL something and identify, and then for DL, and that again takes some time, and to take a biopsy, and biopsy again take, depending on the hospital, maybe 3 days, maybe 3 weeks, right? If it goes straight to the ENT, then while we can do the FNAC, FOL, and biopsy from the throat together, so maybe maximum in 1 month's time we get the report. Otherwise, it will take 3-4 months sometimes. So if you suspect now, you have to have some knowledge, or if it is a supraclavicular, you have a press lump, don't send to EST. I mean, if you suspect something in the throat, something inside, aerodigestive tract, straight send to ENT. Everybody can do it, but if you send to ENT, it's quicker, because we don't want to waste time in malignancies. Right. Another one, after a bus accident, head-on collision, one patient presents to you with a nosebleed, which has already settled. And what are the investigations? What do you do? This is again a common thing, and X-ray nasal bones. You are writing an investigation, whatever, maybe HB, and we should have some intention. We should get something out of it, right? And it's a very common thing. Our HOs and SHOs, they order X-ray for this. What are you going to get? A fracture nose? Do you need X-ray? It's already there, right? We don't need a confirmation. Even I ask them, and they say JM bonds. JM also without X-ray should be able to tell that there's a fracture, right? It's a waste of time, radiation, right? And also it takes hospital stay also, because if you write X-ray and the X-ray will be done next day, and it's unnecessary investigation. So what is the management? What is the immediate management? Now, this sort of fracture can be managed then and there, because you can see it nicely. It's just a push with local anesthesia is enough. It won't take more than few minutes, right? But most important thing is not that you have to check inside. This is X-ray. I mean, you expect this, no? You don't need X-ray. And most important thing is you have to see inside and to exclude a septal hematoma. You get septal hematoma, this is perichondrial. So that means it cut off the blood supply to the septum. So if you keep it longer, then the cartilage get necrosis. On top of that, sometimes this hematoma can get infected and make the problem worse. And how we do differentiate is if it is a septal deviation and one side is convex and the other side is concave. But in septal hematomas, it's either bilateral concave or one side is straight, the other side is concave. If you want to confirm, just put some probe and push it. You get a boggy feeling. If it is a deviated septum, it's hard. So that has to be done to save the nose. Otherwise, we'll end up with a pedal deformity or a supra depression, which is difficult to correct and which needs 2-3 hours surgery. And sometimes we might have to harvest a rib to get cartilage for grafting because the nose is also not having a cartilage, it's necrosed. And the surgery is also all fibrous, it's difficult. And what about if you see now, first case, you see a nice deviation and you know there's a fracture. But sometimes we get patients like this. So this patient, do they need an X-ray? What do you say? For medical legal purposes, I don't know, they might need it. But for us, what is the purpose? Now, how we manage is we don't know whether there's a deviation, whether there's a fracture, we don't know whether there's edema. The best thing is leave it for about a week or 10 days till the edema settles. Then, if there's a deviation, we know there's a fracture. Then we can correct it. If there's no deviation, there may be a fracture, may not be a fracture. You need X-ray to diagnose? No. If there's a fracture, you're not going to do anything. It will heal on its own. If there's no fracture, again, we don't have to do anything. Medical legal purposes, maybe, but it's sometimes very difficult to say whether there's a fracture or not with the X-ray. With that, if the offender is going to get what is this punishment, I don't know, right? So these patients can wait for about 1 week, 10 days till the edema settles, but you should not prolong it more than that. If it's get delayed for more than 2 weeks, 3 weeks, then the bone will get fixed. And this is one of our patients. They will have a permanent disability like this or deformity like this, which needs 2-3 hours surgery, septorrhinoplasty to correct it. So this took me, I think, 2 hours or 2.5 hours to do it. Whereas if you do it initially, it takes 2 minutes or 3 minutes. And the morbidity also much less. Here you have to do under anesthesia and you have to put a plaster and wait for 2-3 weeks. So the morbidity is more. So wait till the edema settles and do it maybe within 1 week or 10 days, maximum 2 weeks. Nasal foreign body, few things that I want to highlight. Now, this sort of foreign bodies can be removed in an outpatient department. But I know these are children. You have to have experience. You have to have a good light. You have to have instruments. Right? If you are not sure, don't attempt it. Because if you attempt it, 2 things can happen, or at least 3 things. You can remove it, number 1. Then you are all right. The second one, you can push it and traumatize it. Second one, the most important one, for the second time with the children, it will be very difficult. Now the child knows what you are going to do and he will not allow. So sometimes we have to go for GA. So first attempts, you get ready with all the instruments, good light, good assistance, and go ahead. You can either remove it with a hook or probe, right? Or you have to have, if it is like something like sponge, you may not be able to remove with the probe. you need the small crocodile forceps. So that's why I said you have to have all the instruments. You go and with the probe, you go in and see that there's no sort of solid thing. Then you can't go and find your instruments. If you go to that, child will not stay. So you have to have all the instruments on your side. If one fails, you have the other one. And the sucker also. If it beats, you have the sucker. Right? Now, the other more important one is this one. This is not just a foreign body. This is a button battery. Button batteries, they are very dangerous. When it goes inside, now you have a lot of, you have fluid and it has ions. So it completes the circuit, right? And that completion will attract a lot of ions and it erodes. And top of that, if you leave it for some time, this battery bursts and it starts leaking these alkaline corrosive substances. It's very dangerous. If it is in the nose, it can cause septal perforations. If it is in the esophagus, it can cause tracheoesophageal fistula. If it is in the lung, it can cause bronchial fistulas. So it's very dangerous. And sometimes if it is in the esophagus, it can cause later strictures and lifelong problems. So the number one is we should advise all these parents not to let the children to have small batteries and also toys with where the batteries can be removed easily. It's very dangerous and sometimes fatal. If you find that, if you find a battery and you have to remove it immediately, the other foreign bodies, let's say foreign body in the ear, there's no rush. Even you can leave it for 1 or 2 weeks, no problem. But this one, you have to remove it immediately, and also you have to wash it and remove whatever the alkaline materials there. And this sort of patients may need the splint also. Otherwise, you get adhesions and permanent block. You remove it, wash it, clean it, and put something plastic splint and leave it till it healed and remove it up. So the batteries is a sort of a ENT emergency. You have to remove it sooner the better. These are fish bones, and few things I want to highlight here is, and if you read books and they say the infection of the lymph node, this retropharyngeal abscess, the causes, but here is the fish bone. Fish bone, dentures, those things are the commonest. But book doesn't say that because in developed countries where they write books, they don't have bones in the fish. So they write various things, but we have fish bone. Right. And if you get retropharyngeal abscess, how do you identify? Clinically, of course, they have pain or dinophagia. And if you move your larynx and the pharynx, it's tender. And in normal people, you can do it on yourself. If you move the larynx here and there, you can do it yourself and get the feeling, move it, and you get a gritty feeling, cross feeling. Right? So if when there's inflammation in that area, that feeling will not be there. Its movement is tender, and you will see a very nice movement of the larynx and pharynx. You have to suspect there's inflammation. It may be abscess, it may not be abscess, but inflammation. Then we can go for X-ray, and earlier signs as pain, and you see straight spine because of the spasms of the muscle. And if you see that sort of a picture, anybody knows that it's an abscess. And if you see air fluid level, it's an abscess. But we have to identify it before that. So other thing that we use is the widening of the retropharyngeal space. Basically, this here, we take the width of these cervical vertebrae as a guide. If the retropharyngeal space is more than the width of this vertebral body, and you take it as positive. There's something, and maybe early inflammation or early abscess formation. But Yeah, if you see this, is the first picture. You can see the retropharyngeal space is about 3 times. But it's the same patient, the next picture, and there's no widening of the retropharyngeal space. So this is again very important, especially in children. If you take the X-ray in a flex position and also in expiration, you get this pseudo shadow, right? If you extend the head and if you get it in the inspiratory film, and you will see there's no retropharyngeal widening. So when you interpret the X-ray, you have to be careful about the X-ray and time the X-ray very carefully. Otherwise, you will get in a sort of wrong diagnosis. Foreign body aspiration again very common, and sometimes we see positive features in the X-ray, but sometimes we have to go with the history. The mother says the child was having peanut and suddenly start coughing and suddenly coughing and choking and sometimes sweating, and after some time the child was okay, and that history is enough. Because we can't take a risk, we take X-rays and sometimes it's suggestive and sometimes we have to see. Now, this is a very important slide. Actually, this is Dr. Jasavardhana's LRH. Can't. Sound of bronchial asthma. What is it? Is bronchi? And this is bronchoscopic blinding. This is what you see in toys. Yeah, you press the toy and they get this noise, and the child has sort of it's in the lung, it's in the one of the bronchus. So they have this typical bronchial asthma sound. So this video is from Dr. Asavardhan LRH, but I have seen 2 patients. The same thing. One had the sound, one is maybe in the other way or something. He didn't have the sound. But this is very common because they start playing with that. They remove it from the toy and put it in the mouth and start playing, and suddenly goes in. Spelling mistake. The offensive smell in the nose. There are a lot of causes, systemic causes as well as local causes. I'm not going to touch the systemic causes, maybe lung problems, sometimes bronchiectasis, even bad pneumonia, respiratory tract infections, and sometimes some metabolic conditions, even the stomach content, some of the drugs, all can cause smelly breath. But I'm talking about the local causes. It may be a foreign body, especially in children. Sometimes parents don't know whether they have put a foreign body, but the children comes with offensive nasal discharge, usually unilateral. If you get a child like that, it's a foreign body unless proven otherwise. It's an offensive discharge. And the other one is rhinolith, atrophic rhinitis, and infections. Now, this is the first one that I put. It's a foreign body. It's a button battery, and this can come. This child can present with foul smell, and sometimes nasal infections like vestibulitis, furuncles. They can have signs of inflammation and smelly discharge. This is a rhinolith. I talked about one stone, the tonsillar lith, and this is a rhinolith. The same principle can have a small nidus and then calcium deposition, and they can form the smell. I'll tell you a nice story. When I was in Matale, old man, not old, maybe 60s, 70s, and he came, and his wife or children brought him, and this man wanted to commit suicide. The reason is his grandchildren refused to come to him because he was smelling. Right? So that is disturbing. These people, they all refused to come, and this man wanted to commit suicide. And see that the patient was having a rhinolith. Smelly in the sense it's very bad, nauseating smell. It's usually the other thing is atrophic rhinitis. Right? You see a lot of crust, usually greenish crust in the nose. And this can be due to excessive surgery also. We call it after excessive surgery empty nose syndrome. Otherwise is atrophic rhinitis vasculitis. Vigorous granulomatosis is one of the causes, but any vasculitis conditions can cause this. And they have crusting in the ears, in the nose, and this crusting destroys the ear. It destroys the nose, sorry. So when you see crusting, you clean the crust, you see a very spacious nose. And the problem is, it's very spacious. If you see through the nose, you can see the postnasal space straight away. But these patients complain of blocked sensation because there are no nerves. They don't feel the breathing. The main complaint is blocked nose. Regarding smell, the patients, the olfactory mucosa is also gone. They don't feel the smell. But it's only the others. And this is common in young females. So there are a lot of problems in getting marital life, right? And I have treated some patients who couldn't get married and some patients who wanted to get divorced, right? And wife, that was a male partner, and brought him to me. Antima part of Gila Balam. You see that is atrophic rhinitis. Very smell. You can't go close. And the patient, you say, you are smelly. I'm not smelly. I'm perfectly fine because the patient can't feel it. The olfactory epithelium is gone. The other condition is sinusitis. That also can give rise to a smelly breath, smelly discharge. It may be usually maxillary, and sometimes you get fungal sinusitis. And there we can do what is called enteral washout and clean the sinus and treat with antibiotics. Or if not, if it not get cleared, we'll have to go for surgery. At the same time, we'll have to treat whatever the underlying problem. And if you have unilateral maxillary sinusitis, you have to always check the teeth, upper teeth, because the problem may be in your mouth, not in the nose. If you just treat the nose, it will recur. And sometimes even after tooth extraction, you will get what is called oroantral fistula. I have seen patients, they complain of rice coming out through the nose. After tooth extraction, they get a hole, when they eat, rice goes to the sinus and it comes out through the nose. So if you see a patient with unilateral maxillary sinusitis, always check the teeth. It's a possibility. I'll stop after this. I have a lot of slides and can do it for another hour or two. I'll stop it now. Time is I think. And this is again a common thing. Is it is called seroma. You get serous fluid accumulated under the perichondrium. Is usually harmless, but if it get infected, then it's a problem. Why I said harmless? Because it's unilateral. You can remove the seroma by aspiration, but it can recur. So we do incision and drainage at the same time. Whatever the method, we have to apply pressure. Otherwise, it recollects. The more important and dangerous one is hematoma. Again, similarly, that we discuss about the septal hematoma. Here also it can cause destruction of the eardrum. Destruction of the cartilage, giving rise to what is called coliform ear. It's common in football players, rugby players. That's why they wear ear protectors. And also in among our people, sometimes these girls, they like to pierce their ears, not through the ear lobule, the up also through the cartilage. And if you don't do it under aseptic condition, they can get into this problem. If you treat early, then you can reverse it. But if the cartilage gets necrosed, it's like chronic osteomyelitis. It's very difficult to treat because the cartilage is necrosed and no antibiotic will go in. So if you get into this problem, the correction is also very, very difficult. And you will never get a normal looking ear. It's better to put a prosthesis than try to correct this. You can't get a normal ear. You can't get the shape. So it's better, the prevention is better than these surgeries. Yeah, since I have a lot of slides, but I will stop here. So again, thank you very much. I think I have covered not very high-fi ENT, but common ones that we encounter in day-to-day practice. So again, thank you very much, the KSM, and for giving me this opportunity. Thank you. Yeah. Yeah, if there are questions, then I can answer. Yeah, tinnitus, it has sort of vast spectrum. It may be just idiopathic and you don't have anything, right? They can get stimulation of the this eighth nerve and can give rise to tinnitus. Again, you have, you can differentiate it to vascular tinnitus and the normal continuous tinnitus. We are talking about the continuous type of tinnitus. With vascular tinnitus, we have to think of various other things. Continuous type of tinnitus, it can be just due to no reason. Yeah, you can reassure the patient and try to ignore the things. And drug-wise, sorry, we can give fluorescein, but the most important thing is reassurance them, and you have to take some time and explain to them. In other countries, there are tinnitus societies even. You have a patient with tinnitus, and the other patient share their experience with the person who is having tinnitus. So they try to manage tinnitus, and sometimes it's so bad they can't go to sleep. It's ringing, it's very high pitched noise. They can't. But so from that spectrum, the other extreme the spectrum, there can be other sort of underlying causes. So in that case, we have to look for it. So merely from reduced hearing to those temporal lobe problems, they can have it. So the presentation with tinnitus is very unlikely now. So as an example, if you have unilateral hearing loss, then we go for MRI scan. There are the chances of having CP angle tumors is 1 in 400,000. 1 in 400. The tinnitus has no indication for go for these imaging methods, because the chances of, if you have to do imaging for tinnitus patients, you have to do maybe thousands to find a underlying causes, but it's a possibility. But they have other symptoms also. If they have other symptoms, they can now temporal lobe epilepsy, other than tinnitus, they may be having other symptoms. So we should not depend on tinnitus to go for other things. Yeah, yes. Yeah, tinnitus may be related or even may not be related. Possibility.
I think it came to the end of the lecture. I had to come late because of students are there. I thought to see them today. Before we conclude the session, you announcement that two books written by the Dr. Ratnatunga Pagunavardhana is available in our KSM office, as well as the KSM members, even other doctors who can help us to buy the KSM T-shirt as well as a KSM tie. And next week, next Tuesday, we are having the certificate course on endocrinology. And our annual session coming up on April, and we are calling for abstracts and orations. And for the research, present research in the case. Now this is time for them to apply. It was actually one of the very important lecture. I think what I just always tell this country, normal doctors, particularly people who do private practice, general practice, OPDs, and everyone else, this type of lecture, they should come and receive and listen to these things, and then only they can do the better practice with the brain. Otherwise, just writing something for each and every patient is the practice of this country. Unfortunately, we organize these CME lectures to educate the doctors and students and even others. I think they might not make use of these resources. And now only thing is now we have opened the link on YouTube and Facebook, and through our web, people can listen to this lecture, even not coming here because of the situation. So even they might joining without coming. That's the advantage we have started currently. Now, thank you very much for wonderful lecture. Even it is a really educational, help us to all of us to have this type of lecture to update our knowledge on this particular area of interest. That is, I hand over the certificate of appreciation. And thank you very much again. Have a good day.